Well, welcome again to all of our listeners and viewers for another in the series of interviews with the experts at Mayo Clinic. I'm Malcolm Bell. I'm your studio host for this podcast. And it gives me great pleasure to welcome our guest today, Dr. Juan Bowen, who's an internist here in community internal medicine, but is maybe better known in cardiology, following his advanced cardiology training as an expert in thoracic aortic disease. Dr. Bowen is the former director of the Mayo Marfan, a thoracic aortic clinic, but maybe better known, certainly here in Rochester, really as a master clinician, and has been the recipient of the very prestigious Distinguished Clinician Award by Mayo Clinic. So, Juan, it's truly a pleasure to welcome you this morning.
Thank you. Happy to be here.
So, this morning we're going, and this is going to be a series of brief podcasts, and this is the first in this series. And today we're going to be talking about the differential diagnosis and workup for thoracic aortic aneurysms. And maybe we'll just start off by asking you, what is the definition? What is the current definition of a thoracic aortic aneurysm in terms of location and size? And what is the differential diagnosis that you always need to consider when you see these patients for the first time?
Sure. Well, the formal diagnosis of an arterial aneurysm is 1.5 times the normal diameter. But that definition doesn't quite work for thoracic aortic aneurysms because there can be consequences before they reach that traditional definition. So a better way to define a thoracic aortic aneurysm would be using a Z-score, for example, Z-score greater than 2, or looking at tables, which we have, of expected size. The aorta does grow throughout the life cycle and does increase in size. And also larger people have larger aortas. But there are publications with normal values, and you can look up your patient by body surface area, age, sex, and see what the normal range is. And that's really a better way.
Okay, so not one single number. And so that's good to hear. And then as you assess these patients, and these are patients who get referred to you, what are you considering in the differential diagnosis when you see these?
Yeah, that's an interesting question because the referral reasons have changed. When I started seeing these patients years ago, it was often the referral was from a clinician who had recognized something in for example, the patient's body type. This patient appears Marfanoid. Could they have the Marfan syndrome? That was a common way and they still get referred that way. But more commonly today, they're referred because an imaging study has identified an enlarged aorta. Very often the calcification, a coronary artery study, or another CT, a CTA done in the emergency room. So now this is a very common way that people get referred. So you kind of have the imaging study before you have the patient. But the differential diagnosis is not that complicated. And it boils down to a genetic causes and acquired causes. And when we first see the patient, we think, could this patient be in a syndrome category? And there are not that many of those. Typical ones we see in our clinic are the Marfan syndrome, a related TGF-beta pathway disease, the Loeys-Dietz syndrome, and then a completely different one, the vascular Ehlers-Danlos syndrome, which is a collagen 3 mutation. We see many patients with bicuspid aortic valve aortopathy, keeping in mind that during embryonic life, the aortic valve develops together with the first portion of the aorta. And when you have a bicuspid aortic valve, you have a weak aortic wall. And then there's an important category, which is an inherited tendency towards aneurysms in people who do not have syndromic physical features. This is known as a familial non-syndromic. These people have a normal phenotype. And they can be challenging to understand. You have to evaluate the family members. So there's that group. And then for the acquired ones, probably the biggest group that we see that are acquired would be inflammatory aneurysms. In the patient over 60, this is typically a giant cell arteritis with aortitis. And in the younger patient, the Takayasu aortitis. And then very rarely an infectious cause. Hypertension usually is not a cause of thoracic aortic aneurysm, but it can be with severe longstanding hypertension. And then there are other miscellaneous causes, but you certainly do have people where they clearly have a thoracic aortic aneurysm and you cannot determine the cause.
Yeah, that's very interesting one. You talked about the syndromic, non-syndromic, and the frequency on which you see inflammatory and other acquired diseases. And I guess I'd always thought that it was something that you would see in particularly aging patients who've had maybe uncontrolled hypertension. It sounds like that's sort of the minority of patients that you're seeing today.
That's true. Yeah.
Okay. So, so in that vein, in terms of when you're assessing these patients, there are obviously key questions that you're going to be asking. Well, obviously your family history and symptoms and your examination findings. Can you maybe sort of just briefly summarize what are the key features, the history and exam that you're looking for?
Yes. So the easiest way for me to remember this is to think of cardiac and extracardiac. So in terms of history, cardiac features would be the ones that we're familiar with. Do they have cardiovascular symptoms of any kind? So that's important. Typically, these patients are asymptomatic if it's just the aorta, but they often have valvular disease. Classically, they'll have very often myxomatous mitral valve disease. They have bicuspid aortic valves. They'll have either aortic stenosis or aortic regurgitation sometimes. But extracardiac features are really critical in this family of disorders. Marfan patients, for example, they have musculoskeletal problems, tall stature, low back pain, poor vision. So you focus on those kinds of symptoms. And then with regard to the family history, you can't evaluate these patients with a casual family history like you might do in your regular clinic patient. So we ask them, tell me about your father living, passed away, what was the cause of death? Tell me about your mother, siblings, your own children. Focus on first degree relatives. They're much more important than other relatives. And then ask them some pointed questions. Has anybody in your family had aortic valve disease? Has anybody in your family had an aortic aneurysm? Has anybody in your family died unexpectedly at a young age? So those would be the important questions.
Okay. Then, as you made a really important point, a lot of these are incidental findings. They find their way into your clinic. And so, again, there may be a CT scan. You talked about coronary, CT calcium, so there'll be a non-contrast scan. But maybe you could just sort of briefly tell us, what's your preferred imaging of these aneurysms, sort of a suspected aneurysm? And do you have a preference, of one over the other?
This is a super important topic. And the main point to remember is to use multimodality approach. So not just one type of imaging. The standard imaging in our clinic for the first visit would be two things. One would be an echocardiogram. Good for measuring the aorta, but not as good as cross-sectional imaging, but critical for evaluating cardiac valves, of course. And then a second, either a CTA or MRA, and at a minimum, a CTA, chest, abdomen, and pelvis, because we're looking for patterns. Some people have a root pattern. Some people have an ascending pattern. Some people have branch aneurysms, splenic artery, renal arteries, hepatic artery, iliac arteries. So there's a pattern recognition part to this, and you can't do it without comprehensive imaging. More and more, we're adding head and neck imaging. So the term you'll hear is head-to-pelvis imaging, because we're recognizing that in some of these disorders, there are important findings in the head and neck arteries.
So, and then in terms of follow-up imaging, you choose the one that you used initially, that you provided the most information. And is it just going to be the thoracic aorta if that seemed to be isolated? How often do you have to do the sort of the head-to-pelvis imaging?
Yeah, and the key aspect of this is, what is the diagnosis? So I didn't mention genetic testing yet, but not in everybody, but in more and more patients. It's important to recognize that this field is now an example of precision medicine or individualized medicine. And it is possible to make a molecular diagnosis in many patients. And that will guide your management, and it will guide the practice you're going to follow for surveillance imaging. For example, if the patient has the Marfan syndrome,
Well, we're actually going to talk about the Marfan syndrome in the next episode as well. But outside of an obvious syndromic physical appearance history, are you doing routine genetic testing in the other patients?
Yeah, I wouldn't say routine, but I think where you think the genetic testing will have a reasonable yield. For example, in a patient with syndromic features, it will have a very high yield.
Okay.
In a patient with non-syndromic features, it'll have a lower yield, but that doesn't mean it shouldn't be done. There's still some yield. And particularly when people have offspring, they have 20, 25-year-old children. And as the cost has lowered and the availability has gone up for genetic testing, we use it more and more.
Okay. And finally, we talked about the imaging and the follow-up, and presumably the interval of follow-up probably depends a little bit on the size of the aneurysm when you first see them. But maybe then just tell us, maybe it's a small aneurysm. How frequently do you follow that patient with imaging? And then when should we be thinking about preventive aortic repair?
A common pattern in our clinic would be to repeat the imaging in a patient who has not had previous imaging, to repeat it in 6 months. And then if it's unchanged, then go to a yearly surveillance imaging. And then some people are quite stable. Keep in mind that for the average aneurysm, the rate of growth is approximately 1 millimeter every 3 years. So if you follow people for several years and you see that they have a pretty flat rate of growth, then you can back off and image them less frequently, every 2 or 3 years for a while, or even less than that in the super stable patients. But if there's a genetic diagnosis, for example, a really dangerous disease like Loeys-Dietz syndrome, that's real different, and then they get followed much more closely.
Okay. Well, we're going to hear more about these other diseases in subsequent episodes. So I think we'll leave it here today, Juan. This, I think, is a really sort of good kickoff to this era. And again, I really want to thank you for sharing your experience and expertise with our listeners today. So hopefully they'll be able to join in and listen to subsequent episodes as we explore this really important group of patients. So thank you so much.
Thank you.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Benjamin Hibbert, Chair of the Division of Critical Care Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for you and your patients. Head to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.